What's up, Ninja Nerds? In this video today, we're going to be talking about restrictive cardiomyopathy. If you guys like this video, it makes sense, you enjoy it, please support us by hitting that like button, commenting down in the comment section, and most importantly, subscribing. Also, if you guys want some awesome notes, some illustrations to follow along during this video, please go down in the description box below. We'll have a link to our website. Go check that out. All right, without further ado, let's talk about restrictive cardiomyopathy. So, restrictive cardiomyopathy, it's a dysfunction of the myocardium, right? Yeah. So it's a dysfunction of the myocardium. Why? Well, that's a great question. So the myocardium has some type of like fibrosis or some type of infiltrative process that's going on. It doesn't have to just involve the myocardium. So what I mean is it can also involve the endocardium. So what happens is there is some type of issue where there is fibrosis, whether this fibrosis be involving the myocardium or whether it be involving the endocardium, right? So the inner layer of the heart, and then the middle layer of the heart is the myocardium. Or it could be some type of infiltrative process into the myocardium or endocardium. So it could also be some type of infiltration. Now, what's the issue with this? Whether it be infiltration or whether it be fibrosis into the endocardium or the myocardium, this causes the ventricles to be more rigid. They don't want to actually stretch as much. They become less compliant is the best way of saying it. So because of this fibrosis and infiltration, the problem with this is this leads to a decreased ventricular compliance. And they just don't want to stretch as much. And because of that, whenever blood wants to come into these ventricles during the diastolic process, they don't like it. And so the problem with it is that they have a restriction. They are very, very stingy with the amount of blood that comes into them during the diastolic filling process when the ventricles are relaxing. And so that's why it's restricting blood entry into the ventricles. And this is called a restrictive filling process. And that is pretty much the overarching theme of a patient with restrictive cardiomyopathy. It's a dysfunction of the myocardium due to a fibrosis or infiltration of their myocardium and or endocardium, causing their ventricular compliance, their stretchability, their distensibility to drop, restricting their filling process during diastole. Now the question is, what causes this fibrosis and these infiltrative processes? To be honest with you, the most common cause is actually idiopathic. We don't really know why. So that is the most common cause. However, if we really wanted to see if there was other things going on, we don't know why, but we maybe want to investigate other secondary causes that may be involved. What are those? So the one that I want you guys to not forget is called amyloidosis. The whole process behind amyloidosis is that there is some type of misfolding. You know the proteins that are made by plasma cells, proteins that are made in general. So there's so many different types of proteins. So there's misfolding of proteins. And there's so many different types. These could be certain types of antibodies, like the light chains of antibodies made by plasma cells. This could be proteins, there's a very interesting protein. It's called transthyretin. We'll write it as TTR. Transthyretin is a protein that transports retinol. It transports thyroid hormone. And whenever there is misfoldings of these antibodies, like the light chains of the antibodies, misfolding of this transthyretin protein, they actually don't work very well. And instead of them doing their normal jobs, they like to go and deposit into the myocardium or the endocardium of the heart, leading to the reduced ventricular compliance. Pretty cool, right? So that's one particular reason. All right, what's another condition? Another one is called sarcoidosis. Sarcoidosis, it's this crazy condition where your immune system creates these things called granulomas. And they're very special types of granulomas. Let's actually write it. They're called non-caseating, meaning that the center of the granuloma, there's no necrotic tissue. There's a bunch of different cells. There's something called epithelioid cells, and in the center of it, there's these different types of proteins like asteroid bodies and different types of proteins there. And then around it, there's a ring of macrophages, a ring of lymphocytes, and then some fibrous tissue. And this condition of sarcoidosis, they like to deposit into various tissues. But one of those tissues is the heart. They can deposit all over the place, into your skin, into joints, into your eyes, but it also likes to deposit into the heart. And it can lead to this fibrosis and infiltrative process that leads to reduced ventricular compliance. One thing to not forget, though, is that sarcoidosis, not only does it cause restrictive cardiomyopathy, but it may also lead to dilated cardiomyopathy as well. So don't forget that. All right, what's the last type of like infiltrative disorder that I want you guys to think about? But it also does lead to fibrosis. There's another condition called hemochromatosis. Hemochromatosis is very interesting. So there's some type of like dysfunction in the liver, yeah? The liver makes a protein called hepcidin. And this protein hepcidin, what this does is it regulates or it moderates the activity of a very important protein called ferroportin, because it's very important. And what happens is whenever there's liver dysfunction, this hepcidin is decreased in production. And what happens is this alters the activity of being able to modulate ferroportin. What does ferroportin do? It regulates the absorption of iron across the GI tract and the release of iron from the spleen. Whenever you lose the activity to be able to regulate this process, then ferroportin stops working and iron absorption across the GI tract is unregulated and increased, and iron release from the spleen is unregulated and increased. And this starts depositing into the myocardium of the heart. And now the problem with this is that whenever this iron starts depositing into the myocardium of the heart, it increases the activity of something called reactive oxygen species, which causes destruction and then subsequently fibrosis of that tissue. One thing to remember here is that in this condition that we see here, not only does it occur in restrictive cardiomyopathy, but it also can occur in dilated cardiomyopathy for hemochromatosis. All right, so we get amyloid, sarcoid, hemochromatosis. What else? The next condition that I want you guys to think about is called endomyocardial fibrosis. So in this condition, it's very interesting. Primarily, I want you to remember like younger children. So young children, and particularly young children who are within tropical climates. So particularly tropical climates. And one of those that tends to be a very important one to remember is Africa. And what happens is I want you not only to remember young children, tropical climates, but in these areas of these third world countries, there's obviously higher risk of infections. And not only is there higher risk of infections, but there's also certain types of deficiencies in nutrients. And in these situations of in high infection risk, low nutrients, or nutritional deficiencies, this may create some unknowing, and we don't really know how this happens, but there may be some type of autoantibodies that are produced. And these autoantibodies can lead to inflammation of the endocardium and the myocardium, but then subsequently lead to fibrosis of the endocardium and the myocardium. And if you cause this fibrotic process to occur, that not only involves the endocardium and the valves, but the myocardium, that also is going to cause them to become having a less ventricular compliance and again, restricting their filling process. So that's one another reason I want you guys to remember, okay? The next one is called endocardial fibroelastosis. So endocardial fibroelastosis, this one's an interesting one. I don't want you to go spend too much time remembering it, so we're going to kind of quickly bang through this one. This one also in children, but very, very young, generally like less than 2 years of age, maybe less than or equal to 2 years of age. But what I want you to remember is that these children usually have some type of congenital heart disorder of some kind. Maybe they have some type of coarctation of the aorta. They have some type of ventricular septal defect, truncus arteriosus, ASD, whatever. This puts them at higher risk. And for unknowing reasons as to why this happens, they develop a lot of fibrosis. But their fibrosis doesn't usually involve the myocardium. It pretty much only solitary involves the endocardium and something called the subendocardium, which is a little like connective tissue below the endocardium. And if you cause that endocardium to become really fibrotic, and it deposits fibrous tissue and elastic tissue. So elastic tissue also can really reduce the compliance of the ventricles as well. And so again, with this condition, you can deposit a lot of fibrous tissue, elastic tissue, and the ventricles lose their ability to have good compliance. The next one that I want you guys to think about is called Loeffler endocarditis. This is actually a condition in which you have high amounts of eosinophils, high amounts of these bad boys, these eosinophils. And these eosinophils, when they deposit into the myocardium, they can really deposit here. They can release some interesting proteins that also can cause a lot of inflammation and subsequently fibrosis. They release a protein, if you guys really want to know it, it's called major basic protein. And they can also release something called a cationic peptides. And either way, these things cause inflammation and subsequent fibrosis, primarily of the endocardium. And they may even involve a little bit of the myocardium. Either way, there's fibrosis of the ventricular area, reducing their ventricular compliance. And what kind of conditions would we be concerned about high amounts of eosinophils? Really, there has to be some type of underlying parasitic infection, maybe that's going on here, or some type of drug reaction usually. So these are very significantly involved in drug reactions, and maybe some type of allergic reaction. Maybe some type of allergic reaction. These are the primary reasons that would trigger someone to have a high eosinophil count. But there is one more thing, and it could actually be a leukemia. So in these certain conditions where maybe your bone marrow's having some type of process here, where you're popping out tons of eosinophils. This condition where maybe you have a cancer where you're increasing the production of your eosinophils is called eosinophilic leukemia. And this may be another potential etiology or factor associated with these high bumps in eosinophils. All right, last but not least, this one's probably the easiest one to remember because we know whenever patients have some type of tumor, maybe within their lungs, maybe along the mediastinum, they have a tumor here, or they have a tumor here, or they have maybe some type of Hodgkin's lymphoma, like lymph node involvement, or they have some type of mass around the carina, or a mass around the esophagus. Either way, there's some type of mediastinal tumors, and they're getting hit with radiation therapy as a treatment process. What's near that area? The beautiful old little heart, and it can get hit by that radiation, and it can undergo necrosis and then replace that necrotic tissue with fibrous tissue. And then if you cause that fibrous tissue replacement of the myocardium, you reduce your ventricular compliance and it causes a restrictive filling process. All right, engineers, let's move on to pathophysiology and complications. Let's talk about the pathophysiology and complications of restrictive cardiomyopathy. So we know that the primary issue with this disease is if we were to take into consideration that there is this fibrosis, right? Here's all this fibrosis of the myocardium or the endocardium. And regardless, all of this fibrotic tissue or infiltrative tissue is reducing the ability of the ventricle to be able to expand during the diastolic process. And again, this involves both of them, both the right ventricular myocardium and the left ventricular myocardium. So imagine this process. If there is a decrease in ventricular compliance, and you know what, sometimes if there is this fibrosis, it can encroach onto the actual ventricular cavity and make it a little bit less small, a little bit less big. And so sometimes we also say not only could there be potentially a decrease in left ventricular compliance, but there may also be a decrease in the cavity size of the ventricle. And either way, regardless of that, if there is a decrease in the ventricular compliance, in other words, it doesn't want to stretch, whenever blood is coming from the atria, whether it be left atrium down into the left ventricle, right atrium down into the right ventricle, during the filling process, it'll fill easily in the beginning of diastole, the early diastolic process. It'll extend a little bit. But in the middle and later phases of diastole, it just doesn't want to expand anymore. And so because of that, there is a reduction, a significant reduction in the diastolic filling process, because it's just saying, hey man, I'm not going to let you fill me up anymore. So because of that, if you have less diastolic filling, what does that mean for your preload, the amount of blood that's in the ventricles before they even contract? It's reduced. And if there's a reduction in preload, you subsequently reduce your stroke volume. And if you reduce your stroke volume, you drop your cardiac output. And so in a way, this is a certain type of dysfunction of the heart where it can cause symptoms similar to heart failure, but usually we call this a diastolic dysfunction of the heart. Now, whenever somebody has heart failure, there's two different types of heart failure dysfunction that they can exhibit. One is they can have right-sided heart failure symptoms, and the other one is they can have left-sided heart failure symptoms. You know what's really interesting? In patients with restrictive cardiomyopathy, their right heart failure, we'll abbreviate this as right heart failure, is actually more common. They exhibit more commonly symptoms of right-sided heart failure than they do left-sided heart failure. So less common. So we have to be able to distinguish what are the big things with right-sided heart failure. Well, let's think about it for a second. Let's say that this patient's ventricles are really fibrotic, they're infiltrated, they're reduced ventricular compliance, and so when they want to fill with blood, there's just a reduction in their filling process. So because of that, if they don't want to fill properly, blood won't go into the ventricles, and so if they don't go into the ventricles, they stay within the chambers above that and the channels above that. So what's the channel? Let's say here, the ventricle fills and it says, I've already distended my max, you can't fill me anymore. But it's got a lot more blood in the atrium to give. Well, it can't go into the ventricle, so where's the blood going to go? It's going to go up into the jugular vein or down in the inferior vena cava. And the symptoms that you may actually see here, maybe if it goes up, it may produce something called jugular venous distension. It also, if it comes down the inferior vena cava, it may cause hepatomegaly, right? So swell up the liver and maybe even lead to some type of ascites or fluid accumulation around that. And on top of that, it may extend down through the inferior vena cava into the lower extremities and cause lower extremity or pedal edema. So these are common features of someone developing a right-sided heart failure, right? And again, remember, it's more common for them to have right-side heart failure symptoms in comparison to left-side heart failure symptoms. And again, this is due to a diastolic dysfunction. What would be, if we were to theoretically say this, that the patient did actually have diastolic dysfunction on their left side due to, again, them having some type of fibrosis or infiltrative process of their left ventricle enough that it reduced the diastolic filling process on the left side. Well, if that was the case, again, left ventricle says, hey, I'll accumulate some blood, but then once you reach that early part after the early phase of diastole, I'm not going to take any more. So the mid and the late parts of the diastolic filling process in the ventricles, it says, I'm not taking any more. Well, that blood's got to go somewhere. So what does it go? The left atria says, oh, I guess I'll have to push you back into the pulmonary circulation. And if it goes back into the pulmonary circulation, that can lead to symptoms of pulmonary edema. And obviously, when someone has pulmonary edema, fluid within the lungs, that can present like what's called paroxysmal nocturnal dyspnea, where they have shortness of breath, particularly whenever they're laying down flat during sleep. Or they may have dyspnea just whenever they're walking around or sitting down in their chair. Or if they're laying down flat, just to lay down flat, not sleeping yet. But similar to this, when they're laying down flat, a lot of that actually makes it more difficult to breathe and worsens their pulmonary edema. That also can be symptoms there. So that's the big thing I want you to remember. But again, taking away here that their primary issue, their primary pathophysiological process is a reduction in diastolic filling. And that's the reason they have a reduction in their stroke volume, which can lead to symptoms of right-sided heart failure and symptoms of left-sided heart failure, but more favoring the right. Okay, cool. What are some of the other important signs that we can't forget for someone having restrictive cardiomyopathy? You know what another interesting thing is? Going back to this whole right-sided heart failure symptoms, imagine here again, here's your right ventricle, right? And it's really fibrotic. It's infiltrated with a lot of fibrous tissue. So it distends, right? Whenever the atria go through what's called their early, so you know whenever you have diastole, so you have what's called ventricular diastole. There's three different phases, right? So the first phase is you have your early diastolic filling, so blood that's been sitting in the atria waiting to go down. It's once the tricuspid valve opens, the blood floods down. That's your early diastolic filling process. The second one is the blood that's already flowed down from the atrium to the ventricles. Now blood from the superior vena cava and inferior vena cava will then act as conduits and come down into the atria and then into the ventricles. So that's called your mid-diastolic filling. And the third phase of diastole is when the atria says, hey, I'm going to squeeze down, contract, and it's called the atrial kick. And that's late diastolic filling. And the early diastolic filling process is the only time where the ventricles accept some blood. Afterwards, during the mid and to late, they don't like it. So the blood that's been sitting within the atria, right when the tricuspid valve opens, blood comes down. Ventricles allow that to distend a little bit. But the blood that's been sitting within the superior vena cava and inferior vena cava that's waiting to come into the atria and then into the ventricles, that doesn't go in as easily. And so what happens is blood kind of stays within these channels of the superior vena cava upwards into the jugular vein. And that's why you get that jugular venous distension. Here's what's really interesting. In patients with restrictive cardiomyopathy, what we can have them do is we try to have them take a deep breath in. So we have them take an inspiration. When you perform an inspiratory mechanism, what does that do to the intrathoracic pressure? When you take a deep breath in, your intrathoracic cavity volume should increase, so your intrathoracic pressure should decrease. And if it decreases, the pressure within your chest should drop, and it should make it easy for blood that's sitting within that jugular vein right now to get sucked down into the right atrium. However, in these patients who have this disease, restrictive cardiomyopathy, their pressures in the right ventricle are high. Their right ventricular pressure is high, and their right atrial pressures are high because it just doesn't want to fill. And because it doesn't want to fill because of that fibrosis or infiltration mechanisms, that blood, whenever you take a deep breath in, it should drop normally. But the pressure is just so high in that atria and ventricle that it won't drop during inspiration. And so in inspiration, it should do what? Decrease your thoracic pressure. And then if it drops your thoracic pressure, that should lead to the blood in the jugular vein to decrease. However, in this inspiration process, the thoracic pressure will drop, but the blood in the jugular vein will not decrease. It will not do this. And because it doesn't do this, because the right atrial pressure and right ventricular pressure are too high, this is called a Kussmaul's sign. And a Kussmaul sign is basically when the jugular venous pressure stays distended even during the inspiratory process, which should cause it to drop. In a normal patient, it will not drop in an actual restrictive cardiomyopathy patient. Okay, what else? We'll come back here and think again. So we have a patient here who has that, again, they have this fibrosis of their ventricles. They have this infiltrative process of their ventricles. They're not a big fan of allowing their ventricles to distend, right? And because they don't allow them to distend very much, they just have a very reduced compliance, right? That reduction in compliance, again, causes their right ventricular pressure to be high and causes their left ventricular pressure to be high. Because again, it's such a small, and again, if you have this restrictive filling process, it doesn't want to allow blood to come in. And so imagine having to push blood into a chamber that just doesn't allow for you to be able to push blood into it because it's restricting that process. The pressure in that chamber is going to be very high. And what happens is blood that's supposed to be within the right atrium and the left atrium is supposed to push blood down into these chambers. But if the pressure in these actual ventricular chambers are super high, guess what's going to happen? The left atrial pressure will have to increase over time to be able to push blood down into these high pressure ventricles. And the right atrial pressure will also have to increase over time to accommodate this high pressure in the right ventricle. Also, if you think about it, less blood is actually going to be going down into the ventricles, right? If less blood is going down into the ventricles, more of it stays within those ventricles. And if more blood is staying within those atria because they can't come down to the ventricles, these atria will actually dilate. So the whole point here is that I want you to understand is that these ventricles are very, very rigid and don't want to distend. And so because you have high ventricular pressures, this will subsequently increase your atrial pressures. Also, because there's high amounts of blood in the atria, this will cause the atria to dilate. When the atria dilate and get bigger because regardless of having high atrial pressures that they have to accommodate or because they have a lot of blood within them, so a lot of volume and they have to dilate, when you dilate these atria, think about this valve right here. So imagine them being a normal size and then all of a sudden you're stretching and distending out the atria. If you stretch and distend out the atria, now look at these valves, they're farther away from one another. If they're farther away from one another, that's going to be a problem because during the ventricular systolic process, when the ventricles contract and push blood out through their tracts, some of that blood will go right back into the atria. And so with this atrial dilation, it stretches the actual annulus of the mitral and tricuspid valve. So what does this do again? This atria dilates and it stretches the mitral valve and tricuspid valve, the annulus. And that increases the risk of mitral regurgitation and tricuspid regurgitation murmurs. And so when you're auscultating these patients and listening to their hearts, what may you hear? You may hear a mitral regurgitation murmur and a tricuspid regurgitation murmur due to them having higher diastolic pressures, right, within the ventricle, causing the atria to have to accommodate for that higher pressure and increase, again, their pressure, or a lot of blood staying within the atria because they're not getting able to push blood down into the ventricles. They dilate, stretches the annulus of those valves, and causes mitral regurgitation and tricuspid regurgitation. Okay, what's the next complication that I want you guys to think about here? You know, in these patients here who have this reduction in stroke volume, right? When we say because they have a diastolic dysfunction, they have a reduction in stroke volume, that could mean a reduction in cardiac output, right? And the problem here is if we have a reduction in cardiac output, and let's say that this is particularly on the left ventricular side, that could mean that you have a reduction in coronary perfusion. A reduction in coronary perfusion. Now the problem with that is, let's think about this. If there's a reduction in coronary perfusion, less blood is running through this coronary artery here. If less blood is running through this coronary artery, that means less oxygen can be delivered to this myocardium. If I can't deliver as much oxygen to this myocardium as I would like, what can that lead to? Reduction in oxygen delivery to lead to the myocardium can lead to ischemia. The problem with ischemia is that obviously that may lead to symptoms like angina. It may lead to particular symptoms like dyspnea on exertion. But what's the most fearful situation that could potentially happen here? Ischemia, especially if it's severe enough, could increase the permeability of cations flowing into this. And if the cations roll into this cell, it could increase the risk of high electrical discharges. And one of the worrisome signs here is that a patient starts going into something called VTAC or ventricular fibrillation. And this puts them into sudden cardiac death. This is nowhere near as common if you were to compare this event of VTAC and VFib with hypertrophic cardiomyopathy. It is extremely more common in comparison to restrictive cardiomyopathy. But it still can sometimes occur if the coronary perfusion is reduced significantly and the ventricles do increase their thickness in response to the fibrotic mechanism. But please don't get that confused. This is way more common in hypertrophic cardiomyopathy. Okay, let's come down. All right, what's another particular complication? You know, another interesting thing is whenever you have those atria, they dilate. So whenever the atria dilate, like they did in that patient over there, which increased the risk of regurgitation, right? So let's balloon up these atria a little bit. Let's say that I balloon these bad boys open. So here's your new atria. They're all super dilated now because of that high pressure and because of the high volume. Whenever the atria end up going through this dilation process, you stretch them out. Do you think the myocardial cells like to be stretched out beyond their normal length? Do you think that alters their electrical activity in some way, shape, or form? Yes. And so when you really cause the atria to dilate, you increase the activity of arrhythmias. And that particular type of arrhythmia that can happen when you dilate these is called atrial fibrillation. What's the concern with atrial fibrillation? It's that you have some type of like reentrant circuit here, which is creating these abnormal atrial contractions. And if you lose that atrial kick, you cause stasis of blood to occur within the atria, increasing the risk of forming clots. And the high risk fear for here is that you can increase the risk of clots that could actually cause an embolus and break off and go and cause a stroke. That's the eventual concern. You know what else is really interesting, and this is one of the scary things, is in conditions that involve the endocardium, such as endomyocardial fibrosis, such as endocardial fibroelastosis, such as Loeffler's endocarditis. What did that do? That caused fibrosis and inflammation of the endocardium. If you inflame the endocardium or injure the endocardium, that is one of the other things of Virchow's triad. Endocardial damage, which is endothelium, increases the risk of forming clots. And so because of that, they can form thrombi, what's called mural thrombi on that fibrotic or inflamed endocardium. And so again, what I also want you to remember here is that whenever there is the fibrosis of the endocardium, there has to be some type of injury that leads to that process. And now the endocardium isn't as good as being able to maintain its antithrombotic state. That increases the risk of what's called mural thrombi. And the problem with that is that if you have mural thrombi, they can embolize and break off and cause a stroke. So another particular thing is that these patients are also at high risk for thromboembolic events. Man. Okay, what else? Here's another interesting thing. If we have infiltrative disorders and fibrotic disorders, you have your conduction system, right? So you have your SA node, your AV node, your bundle of His, bundle branches, all that stuff. Imagine I put deposits somewhere along the AV node. I deposit along the bundle of His. I deposit along the bundle branches. When I do that, I'm depositing along these areas which are conducting electricity. So what am I doing? Again, I'm having depositions, deposits in the electrical system, right? And imagine if I put some deposits into the AV node And then now the SA node is trying to send signals down to the AV node. And I have these depositions in the AV node that are now altering its electrical activity. Are you going to be able to have the AV node receive signals and send that down to the ventricles? No. And so because of that, that increases the risk of what's called AV blockades. If I have some type of actual deposition or fibrosis of like a bundle branch, like the left bundle branch, and now that actual electrical activity that's moving through that bundle branch is diminished, are you going to be able to get electrical activity to go down into the left ventricle? No. And so this may lead to a left bundle branch block, or maybe even a right bundle branch block. So these are very concerning things as well. The last thing is, if I put all these depositions within the myocardial tissue, this myocardial tissue, can it generate a lot of electrical activity if it's fibrotic or it's infiltrated and it's destroyed? No, fibrous tissue isn't able to generate good electrical activity. It won't generate any electrical activity. And so because of that, think about the vectors that are being produced. So imagine the more myocardium you have, right? That's why in left ventricular hypertrophy, when you look at like the R waves, if you have a very thick left ventricle with lots of good myocardium, it's going to produce a very strong electrical vector, which will cause a large R wave. But if your myocardium is replaced with fibrous tissue, non-contractile, non-electrical conducting tissue, are you going to be able to produce a nice vector? No. So because of that, another interesting thing that you may see in these patients is they may have what's called a decrease QRS voltage, particularly their R wave may be reduced. And that's also something to think about. Okay, last but not least in these patients, very important thing here is that, you know, these ventricles, again, they're super fibrotic, they're infiltrated, they're reducing their filling process, right? Remember I told you that because the ventricles, again, have that decreased compliance, right? There's a reduction in the compliance of the ventricles, right? And so because of that, they have high right ventricular pressure and high left ventricular pressure. Now, what's interesting about this is that, remember I told you within the filling process, there's 3 filling phases: the early diastolic filling, mid diastolic filling, and the late diastolic filling. Early is whenever the tricuspid valve open, the atria are filled with blood right now. They're gonna just dump that blood right into the ventricles. Remember I told you in this phase is where the ventricles are the most compliant and they'll allow for that blood to come in. The pressure in the ventricles are going to be the lowest at that point in time, whenever they're in the early phase of diastole. And the atria, remember, what happens to the atria because of them having high right ventricular pressures or left ventricular pressures? This causes the atria to dilate, and it causes their pressures to be higher. So naturally what happens in this situation is that you have high right atrial pressures and high left atrial pressures, and they're dilated. So they can take on a lot of blood. What happens is right in the early phase of diastole, right when that tricuspid and mitral valve opens, these atria are just going to allow for tons of blood to rapidly flow into the ventricle very quickly in the early diastolic filling. So what happens is, right in the early diastole, there'll be a very, very rapid filling. Very rapid. And because this filling is occurring so rapidly, it'll actually cause a lot of turbulence into the ventricles, which will produce a very interesting type of heart sound. And you know the heart sound that you hear whenever you have, okay, first one here is your S1 heart sound, and then here you have your S2 heart sound. Well, right after S1, right, so we're getting ready to start in the beginning phases here. You have S1, and then you have S2. What happens is in these patients, they have this period where right after S2, we're in this early diastole, and then we'll go into another one called your S1. So here we're going to have systole, and then you're going to have at the S2 point, we're going to go into diastole. So from S2 to S1 is diastole, from S1 to S2 is ventricular systole. So from S2 to S1, here we'll have early diastole, mid diastole, late diastole. At what point in time is blood rapidly flowing into the ventricles? In early diastole. So in the early phase of diastole, you'll have so much blood flowing in, it'll produce this turbulent blood flow that it'll create an extra heart sound. And this extra heart sound is called a S3 heart sound. So what kind of heart sound would you hear in these patients? An S3 heart sound may be auscultated. Now, believe it or not, over time, if these right atria and right ventricles, they start actually enlarging and then they do hypertrophy to account for these higher pressures, they may eventually, in the later diastolic phases, their ventricles may be, their atria may start thickening and hypertrophying to the point where they actually clamp down and contract and create a high atrial kick. And so sometimes, in very severe cases, you may get an S4. But it's not too common. It's more common for them to have an S3 heart sound, and in some cases, in severe cases, where the right atrial enlargement and the left atrial enlargement occur to the point where they get hypertrophic, they can produce an atrial kick, which could create a S4, but it's more commonly an S3. Now that we've covered that, let's talk about the diagnosis. All right, so let's talk about the diagnosis of someone with restrictive cardiomyopathy. So, whenever we're talking about like diagnostic tests for a patient, obviously when these patients come in, they sometimes can be completely asymptomatic, right? A lot of the cases of cardiomyopathy may be asymptomatic, but if they do come in, they may present with some types of dyspnea, right? Because of the left-sided effects, right? Causing some pulmonary edema. If they do have some small reduction in cardiac output to the point where it's reducing their coronary perfusion, they may present with some type of ischemic chest pain like angina, dyspnea on exertion. So there can be certain types of symptoms that they may present with. Or they may come with right-sided heart failure symptoms, right? Some jugular venous distension, some pedal edema, things of that nature. So when you have someone coming in with any signs of like concerns for heart failure or concerns for any kind of acute coronary syndrome or anything like that, chest pain, shortness of breath, you usually order two common tests, which is a chest X-ray and an EKG. They're not going to yield a very significant amount of very specific or sensitive information for a patient with restrictive cardiomyopathy, but you're going to do it because of their common chief complaint. So a chest X-ray, what would we potentially see on this? Again, it's not going to be specific, but if they do have left-sided heart failure symptoms, so if left-side heart failure symptoms are present, they may have some pulmonary edema. They may have some pleural effusions present. So these could be particular symptoms that you may see or particular findings is there may be pulmonary edema, or if there's not that, there could also be maybe some small pleural effusions. But again, you have to remember these are relatively non-specific. That doesn't tell me that there's a cardiomyopathy. So it could be pulmonary edema, could be pleural effusions. Now, if you look at the heart on this one and you get a good enough look at it, you may be able to see that there is some atrial enlargement. So there may be some obvious atria enlargement present. But again, still tough to kind of differentiate that. So that's what I would say for the chest X-ray. For the 12-lead EKG, you may pick up some interesting things. So for the 12-lead EKG, again, what were the things that we said? If you guys remember, we said that it could actually very significantly cause atrial enlargement, right? And the atrial enlargement irritates the atria, stretches them out, causes alteration of their electrical activity, and increases the risk of atrial fibrillation. So you may pick up some type of arrhythmia, such as atrial fibrillation. The other thing that I said is that it could actually cause deposition, right? We could have deposits of the infiltrated tissue or fibrotic tissue into the conduction system. And if it deposits into the AV node, it can cause a AV block. If it deposits into the bundle branches, it may produce a right bundle branch block. It may produce a left bundle branch block, right? So these are potential things that you could see as potentially some type of AV block, maybe some type of atrial fibrillation, maybe some type of right bundle branch block or left bundle branch block. And then also if there's deposition of fibrous tissue within the myocardium, that reduces their electrical activity. And so what happens with that, if you reduce their electrical activity, especially during the QRS complex, when it's supposed to be moving down to the ventricles and producing a nice QRS vector, the mean QRS vector may be reduced because you don't have as much myocardial tissue. It's kind of replaced with fibrous tissue or some type of infiltrative process. And so they may also have low QRS voltages. Okay. These are two things, but again, it doesn't really tell me much. So if I had to say, okay, you were asking a question or you were asked by your attending or you were told, like, hey, what kind of test would be best to determine someone has restrictive cardiomyopathy? An echocardiogram would probably be the first thing to start off with. So let's say you had some of these things and it didn't really tell you much and like, man, I don't know what's going on. I'm going to get an echo. An echo is going to be a pretty good thing to look at. So let's say that we take a look at the heart where we actually cut it like this and we look at it in this way, or we look at it in this kind of normal configuration. In this configuration here, you see the right ventricle, you see the left ventricle. Now in patients with this types of restrictive cardiomyopathy, their issue is that they don't really have any obvious like asymmetry of their ventricles. They're not like asymmetrically thickened at one point and area. So they're relatively, if you do potentially see anything, there may be some type of thickening of the ventricles, but they're going to be symmetric in comparison to something like hypertrophic obstructive cardiomyopathy. So if you do see any type of thickening, it'll be symmetric plus or minus symmetric thickening. And if you look at the lumen of the ventricles, sometimes that also can be a little bit small, but again, it depends. So sometimes if the fibrosis or the particular fibrotic mechanisms of the actual ventricles do occur to the point where it really makes it very rigid and it can potentially reduce the diameter, that is another potential possibility. And that sometimes you may see a decreased diameter of the ventricles. But again, this is always nothing super obvious here. So there could be a reduction in the diameter, there could be some symmetric thickening of the ventricles, but again, these aren't like a super obvious thing. What else could come up off the echo? Well, if you take a look at their atria, their atria are going to be gargantuous, right? So they've got these big old atria. So one of the things that you will see is biatrial enlargement. And whenever you actually utilize Doppler flow and look at the actual dynamic activity of the ventricle, you'll be able to see that whenever blood is coming into the ventricles during their diastolic process, there's a significant amount of diastolic filling problems. So there is a significant reduction in diastolic filling. But here's the last thing. When you look at the actual ventricular contractility and the ability to push blood out of the ventricles, there may be a reduction in the diastolic filling where it drops the preload, but the contractility is somewhat preserved in the sense that they don't really have a significant reduction in their EF, or really any reduction in their EF. And so sometimes when you look at the contractility of the ventricles, their ejection fraction is oftentimes relatively normal. In some cases, if the fibrosis is pretty extensive to where it does involve a good chunk of the myocardium, there is the possibility of a reduction in EF. But for the most part, it's relatively normal. With extensive fibrosis, there potentially could be a reduction in EF. So we could also say if there is significant fibrosis or extensive infiltration, there is the possibility of a reduction in EF if you're replacing a lot of the contractile myocardial tissue. So these are the things that I would definitely say that you can pick up off of the echo is you may have some symmetrical thickening of the left ventricle walls and the right ventricle walls. The diameter may be slightly reduced with extensive fibrosis, but the big things to pick up on in this echo is they are going to have biatrial enlargement, a reduction in diastolic filling, and also when you look at their diastolic filling process, their left ventricular end diastolic pressure and the right ventricular end diastolic pressure are going to be high. So that's another thing. They have high diastolic pressures. Their ejection fraction is oftentimes normal, but with extensive fibrosis replacing the normal contractile tissue, there is a possibility of a reduction in EF. Another test that can sometimes be ordered, in addition, is becoming more utilized, is a cardiac MRI, because a cardiac MRI gives a good look at the heart, and it may be able to give, obviously it can show you some reduction in diastolic filling, but it may even highlight some areas of infiltration and fibrosis. So one of the things that's interesting about cardiac MRI is it may show up, it may highlight some soft tissue findings. So it may highlight some signs of infiltration or fibrosis in the myocardium, which would make you want to be a little bit more concerned and maybe have a higher differential for saying, ooh, if there's some type of infiltrative process or fibrotic process with the ventricular myocardium, I wonder if it's a restrictive cardiomyopathy. So that's kind of the nice thing about the cardiac MRI, and it's actually becoming more commonly utilized in comparison to endomyocardial biopsies. But that's what I would say for your echo. Big thing for this one is when you're thinking about thickness of the ventricles, it can be thickened, but it's symmetrical. That's the big thing I want you guys to think about. If there is thickening, it is symmetrical in comparison to hypertrophic cardiomyopathy. And dilated, it's very thin ventricular walls. Diameter, it could be potentially reduced if there is a significant amount of fibrosis. Oftentimes the diameter is sometimes reduced though. Biatrial enlargement, reduction in diastolic filling due to the higher pressures, and EF is oftentimes normal. Okay, what are some other tests that we should think about, especially for your exams for restrictive cardiomyopathy? Another thing that can actually be very important to remember for patients with restrictive cardiomyopathy is we can do something called a cardiac catheterization. This is actually interesting whenever you're talking about a patient who you're really thinking about in your exams. When we talk about a cardiac catheterization, we can look at the ventricular activity that's going on here, right? So when we look at the ventricles and we think about the ventricular pressure, so sometimes we can look at what's called the ventricular pressure curve. So we can look at the ventricular pressures in a curve. Something interesting pops up on there that they love to ask on the exam. So here we have our ventricles, right? When the ventricles are going through their first part, so let's say first part is we're going to cover is diastole, right? So during diastole, ventricular diastole, the ventricles should be relaxed, right? If the ventricles are relaxed, right, their pressure should drop. And when their pressure drops, it will make it easier for the blood within the atria to be able to easily flow down into the ventricles, right? Because naturally during diastole, during the early diastolic filling, you want your atrial pressures, so the atrial pressure to be greater than the ventricular pressure, so that blood will naturally flow down into the ventricles. And when that happens, if the ventricular pressure drops, the first thing that you'll see on that pressure curve is you'll see this go from this level point here and drop. Okay? So that's the first part. So this first part here is early diastolic filling. Now, once we get to that part, what did I tell you happens in the later phases? So then you have your mid diastolic filling and your late diastolic filling. I told you in the end diastolic filling phase, the ventricles actually do accept the blood and let the blood come into them. And that's why their pressure drops and they let blood come into them. In the mid to late diastolic filling processes, they're not a big fan and they don't like blood coming into them. And so guess what happens? When the blood comes into them, again, what did I say happens to their end diastolic pressures? They go up. So because of this, their end diastolic pressures rapidly rise. And when they rise, what's going to happen to this pressure curve in the ventricles in the mid and late diastolic filling process? It's going to start to rise. It'll start to rise. And then it'll continue, and then eventually it'll plateau and stay at that until we get to the systolic process of the ventricles. What does that look like to you? So if we go here, pressure drops because the ventricles actually allow blood to come in during the early phase. And during the mid and into late phase, so mid diastolic filling into the late diastolic filling process, they do not allow blood to come into them very well. Their pressures continue to rise and then eventually plateaus off. What does this look like? A square root. So they call this, they give them two names. We call this the square root sign, which is a very common finding in this disease as well as something called constrictive pericarditis. Or we also call this the dip and plateau sign. Okay, so these are big things to think about in this condition. Is if someone went to get a cardiac catheterization and they showed you the pressure curve on the ventricular pressure curve in someone with restrictive cardiomyopathy or constrictive pericarditis, they would have a quick drop in their pressure during the early diastolic filling because they're actually going to allow blood to come into them. And then because the ventricles, once they get to the early diastolic filling, they don't want to allow any more stretching. They don't want to be any more compliant. They don't allow blood to come into them. Their pressure rises, and eventually plateaus, produces this square root or dip and plateau sign. Okay, that's for the cardiac catheterization. Don't forget that. The last thing that I want to talk about is the endomyocardial biopsy. So in these patients here, again, this would actually be thinking about it. Think about this pretty simply. If you have somebody who has some type of infiltrative or fibrotic disorder that's involving their myocardium or their endocardium, if you wanted to know exactly what kind of tissue it is it amyloid deposition? Is it iron deposition? Is it non-caseating granulomas? Is it just fibrous and elastic tissue? Is it eosinophilic tissue? Wouldn't you think if I biopsied that and looked at under the microscope, that would be the most ideal identifier? That would be a pretty good idea. And so what the endomyocardial biopsy does is you take a sample and it helps you to identify the etiology, right? So it'll help you to kind of nail down, oh, there's eosinophils in this tissue. Oh, there's lots of amyloid deposits. Oh, there's lots of iron. Oh, okay, there's lots of non-caseating granulomas. And so it's really good at being able to definitely nail down what the exact cause of the restrictive cardiomyopathy is. Now that we've talked about that, let's hit it home with treatment. All right, so let's talk about the treatment of restrictive cardiomyopathy. So it's relatively similar to dilated cardiomyopathy or any kind of heart failure treatment, really, right? So when a patient is having these issues, one of the problems that we said for them is that in these patients, they're getting a reduction in their diastolic filling process, right? But the problem is that high diastolic filling process can sometimes make things a little bit worse, right? And what happens is instead of that blood going into the ventricles and then getting pumped out into the pulmonary systemic circulation, it's backing up, whether that be backing up into the lungs or backing up into the lower extremities or abdomen or jugular vein. So we don't want all that blood to just be backing up. So what we can try to do is very gently, very slowly reduce some of that actual venous return, reduce some of that excessive amounts of preload, very, very gently. Don't do it too much, because if you diurese them too much, you actually dehydrate them too much, you reduce their preload too significantly, you can drop their blood pressure pretty good, because they are having a diastolic dysfunction. Their problem is why their stroke volume is dropping is you're not having a great preload. Problem is, though, is we don't want that preload to be too high. So we just want to reduce it a little bit so it doesn't keep backing up into the jugular vein, abdomen, or into the lungs. So how do we do that? How do we reduce the preload? And when I say this, again, be very, very careful. The whole point is we don't want to cause any kind of edema, right? We want to reduce the incidence of edema, whether that be peripheral edema or pulmonary edema. And so one of the ways that we can do that is we can reduce the volume of blood within the actual vasculature. And so one of the ways we can do that is we can help to cause we can restrict sodium and water intake, okay? So we can restrict sodium and water a little bit. The other thing is if that isn't working and we're not restricting enough sodium and water and there's still a little bit of fluid overloaded and extending their jugular vein, having a lot of lower extremity edema, having pulmonary edema, we can consider things like diuretics. Because diuretics will help to pull some of that little bit of sodium and water out of the actual circulation. But these are pretty much the main things. You don't really want to mess with nitroglycerin. You don't really want to mess with a lot of the other kind of medications as well. These would pretty much be the main ones that you kind of want to stick with here. Is again, very gentle diuretics, and again, very mild sodium and water restriction. That's really it. Okay, and again, let's be careful. Let's actually put this down. Gentle. Okay, you don't want to do too extensively because you could drop their stroke volume and their cardiac output, make them hypotensive. The next thing is we want to try to reduce afterload, right? So again, when you think about a patient's, their stroke volume is dependent upon three things, right? It's dependent upon preload. It's dependent upon their contractility. And the last thing it's dependent upon is their afterload. In these patients, their contractility is fine. That's not the issue. Their preload is a little bit, off in these patients because they're not getting a good amount of preload, so they have a reduction in preload. What we can try to do is we can try to fix this afterload a little bit. Sometimes if we fix the afterload, that reduces the amount of stress on the ventricular myocardium. And so what can we do to just mildly reduce the afterload? And again, this goes back to it. We want to be really, really gentle. What the whole point of reducing the afterload is to decrease the stress on the heart. Okay, so we want to try to reduce the stress on the heart. Problem is, though, is that you have to be very cautious. Because in these patients, utilizing these, you may dilate the vessels. And if they already have a low preload, which is dropping their stroke volume, and you reduce their afterload pretty significantly, sometimes that can drop their pressure. So you have to be very careful because this can potentially produce hypotension. So how do we reduce the risk of hypotension? We are very, very gentle with giving medications that can reduce afterload. In other words, we want to dilate these arterioles. What kind of drugs would work to dilate your arterioles? You can consider drugs like ACE inhibitors and ARBs. You can also consider drugs like hydralazine, or you can consider a drug called isosorbide dinitrate. Okay, so these are things that you could definitely consider in these patients. So again, very gentle reduction in preload with sodium and fluid restriction, as well as diuretics if need be, and they're still overloaded because of the edema in the lower extremities or in the lungs. Reduction in afterload just to reduce the stress that you can put on the heart so that it can get a good stroke volume and a good cardiac output. That's the whole goal, is if we reduce the afterload, that'll help to increase the stroke volume because their contractility is fine, but their preload's low. And if their preload's low, that's going to lower their stroke volume. So we can try to fix that stroke volume by reducing their afterload. We reduce the afterload, we reduce the stress on the heart and help to increase the stroke volume. But if you reduce the afterload and dilate these vessels, the concern with that is it could actually drop your blood pressure. So be very cautious and give these drugs only if their blood pressure can tolerate it. Okay, what about the last couple things here? Okay, what was the other thing that we wanted to talk about with these patients? Well, they could have conduction blocks, right? That is a possibility. But one of the other more common things is because they get these atrial enlargement, that biatrial enlargement, one of the big issues with these patients is that they have a high risk of atrial fibrillation. And if you have someone who has atrial fibrillation and they also have what's called a rapid ventricular rate, in other words, they're getting a little tachycardic, we want to try to address this. So we can give particular medications that can actually help to slow down, decrease your rate, and decrease the risk of these arrhythmias getting out of control. So there's actually receptors on these conduction system structures, like beta-1 receptors. I could give drugs that act on these beta-1 receptors and block them and reduce the conduction. What are those drugs called? Beta blockers. And so we could reduce the rate by giving drugs like beta blockers, metoprolol, esmolol, things of that nature. The other thing I could do is I could block the calcium channels which are present within these conducting cells and myocardial cells and reduce the calcium entry, which reduces the electrical potentials and reduces the actual contractility as well. And these could be calcium channel blockers such as diltiazem, verapamil. So other things that we can consider in these patients is if they have these high risks of atrial fibrillation with tachyarrhythmias, where they're getting a little tachycardic, we can consider reducing their rate, having a rate control mechanism with beta blockers and calcium channel blockers. Okay? With the conduction blocks things, there's sometimes you may even require a pacemaker if it gets to the point where they do have an AV block. So the other thing is to consider here is if they have a significant AV blockade, like if it's really significant, they may need a permanent pacemaker, and stay away from beta blockers and calcium channel blockers if that is the case, because you could drop their heart rate even more. Okay, what else could we do for these patients? So the other thing to consider here is anticoagulation. Remember I told you that they have risk, a couple things. One is they can have atrial fibrillation. That increases the risk of thromboembolic events. The other thing is that they can have what's called mural thrombi, and this could be due to the fibrosis that occurs of the endocardium and fibroelastosis, endomyocardial fibrosis, and Loeffler endocarditis. In these conditions, you get endothelial dysfunction, injury, and reduction in antithrombotic activities, and you can form clots on them. So we want to consider anticoagulants in these patients because with having an AFib and having mural thrombi, they have a high risk of embolic events. And so we may need to consider something such as warfarin. So sometimes we can consider something like warfarin if need be, especially if they have some type of like mechanical valve, or we can consider something like DOACs, things like rivaroxaban, apixaban, dabigatran to reduce their risk of throwing those thromboembolic clots and getting a stroke. All right, unfortunately, these patients, we have to treat their underlying cause. And usually the underlying cause for these are something like amyloidosis, right? Or sarcoidosis, hemochromatosis. Obviously we want to treat those things. But sometimes these causes produce such irreversible damage to the myocardium that once you have this extensive fibrosis, this extensive scarring, there is no way that we can truly fix or repair or cure that. The only way that we can truly fix this is that sometimes, again, because of the increase in fibrosis, the increase in the scarring, the increase in the infiltrative processes, it just produces irreversible damage. And the only way that you can reverse this is by getting something called a heart transplant. And that is the only way. You can try to treat the underlying issues to prevent the progression. Obviously, if someone has amyloidosis, they may need some type of chemotherapy, monoclonal antibodies. If someone has sarcoidosis, they may need steroids or DMARDs. If they have hemochromatosis, they may need iron chelating agents as well as some type of phlebotomy. If they have Loeffler's, they may need steroids as well. So you get the whole point. We can try to treat those underlying causes, but the damage that's already occurred is done. We can't reverse that. And the only way we can fix this is these patients sometimes often need a heart transplant. So my friends, that covers restrictive cardiomyopathy. I hope it made sense. I hope that you guys enjoyed it. And as always, until next time.